All right. Well, great document that you've put together in regards to the shoulder assessment. The screenshots certainly help. It's very organized with the range of motion in the first column, structured and implicated notes in the middle, and then the photos for visual reinforcement in the final. So I'll take them each in turn in regards to what we're looking for. So yes, you're correct. Here we are looking for premature scapular elevation and or insufficient scapular upper rotation. In that case, you would need to reveal the body region in question, have the person take their shirt off and be viewed from the posterior side. Or even from the sagittal. Additionally, with the abduction, you're looking for a flexion drift where they actually don't get purely into the overhead position, and they actually their arm drifts into flexion as they achieve 120 or greater. Consistently, I'm having them go with their thumb up in the plane of the movement that they're doing. So in flexion, the thumb would be pointed forward, the palm would be facing medial, and with the abduction, they are thumb up again and palm facing forward. The only other elements that I don't see here that are also limiting is the thoracic spine extension, and more importantly, I think would be the latissimus and the teres major, both of which would have implications on the limited overhead motion. Otherwise, look, yes, I agree with all. Next is going to be the shoulder external rotation. Yeah, I can't say it's at 45 degrees. It's actually closer to 30 degrees of abduction with a slight elevation into the scapular plane. So there's a small towel that's under the elbow that brings the humerus into the mid-axillary line of the body, and the thickness of that towel is going to be dependent on the person's body size or torso thickness. As far as the limiting structures here, so yeah, it's going to be the medial glenohumeral ligament, and coracoid ligament, and subscapularis. Yes, that is accurate. The closer they are to their side, as I alluded to, I usually do this at 30 degrees rather than 45. That is going to be more of a subscapularis restraint. They've looked at different EMG studies and internal strain gauges, and it's usually the middle portion of the subscapularis. And I also like the way that you highlighted the knees bent, prop up shoulder with towel. Yep, all of that is accurate in supination for the patient. Norms of degrees, yes, you would expect about 90 degrees of external rotation. People will be plus or minus that, but 90 degrees would be what you would expect. And internal rotation is done passively by the therapist. You are correct. Again, in a supinated position. Keep in mind that as they transition into that internal rotated position, there's sometimes people will get a kind of a clunk on the front of their shoulder as they're, what I interpret is the greater tuberosity just kind of gliding through or articulating with the anterior rim of the glenoid. So just be conscious of that. And keep in mind that you're not compressing the ball in the socket. You are really just more stabilizing the scapula such that you're not getting, so that the motion is purely glenohumeral rather than scapula thoracic as well, contributions. And then inhale and exhale at the end. Yep. Okay, next position of rotation is going to be at your 90-90. Humeral head is more, so we'll take it each in turn in each, that is each column. Supinate the wrist for internal and external. Pretensions of tissue. Yep, one goes on the radial styloid or the ulnar styloid. Correct. It's on the bony prominence depending on which one you're measuring. So if you're measuring the external rotation, it's on the pinky side, and then on the internal rotation, it is on the thumb or the radial side. Make sure that they go through full inhale and exhale fully at both end positions to take out any contributions from what their breath position may otherwise, their breathing and how much air they may have in their thorax may influence their ranges of motion. Yes, I can confirm that it's because the anterior capsule or anterior structures are stretched or tensioned because they are providing the anterior restraint that it and the ball is wanting to go forward as you go into end range external rotation in that cocking position. And yes, those structures are all accurate. Um, Structures tensioned in passive internal rotation at 90 degrees of abduction, posterior capsule, infraspinatus slash teres minor, yes. Posterior labrum, yes. Yes, this is accurate. I can confirm that. Expect 90 degrees of external rotation. Total arc should be 160 degrees. That's correct. And then you're comparing it side to side. That is their total arc should be within, there's a debate, but within 10 degrees would be ideal. It may be shifted, meaning it may have more external, internal based off their humeral torsion. But that being said, the totality of the degrees should be plus or minus 10. Across body horizontal abduction, grasps the wrist. Patient stabilizes shoulder blade and humerus from rising. Olecranon should be to midline. Yes, that's correct. Midline of nose, that's accurate. And usually that's around 40 degrees or so, 36, 35, somewhere in there. Posterior capsule, posterior cuff, infraspinatus, posterior labrum, compressed by humeral head moving backward. I would say I question that. I would say that usually people get more of an anterior crowding. I don't think that there's I consider there to be more of an tensile rather than a compression on the backside. Um, would be my only variation there. Seated shoulder external rotation and internal rotation at 90 degrees of flexion. Height of the shoulder is height of the elbow for external rotation. That is correct. Structures tension passively into external rotation at 90 degrees, anterior capsule. Yep. And then I would also add in that, JC uses this as a teres minor assessment. So I'm sorry, I said teres minor. I meant teres major. So the teres major can be a limiting constraint here, and oftentimes that muscle, the teres muscle groups will also hold additional tone, trigger points, and tension in the presence of an irritated shoulder, and so that can also be a limiting restraint here beyond just what you've listed above. But the anterior capsule, I can't really say that's and or maybe a little bit of subscap and labrum, but it's going to be more the the internal rotators in a flex position, and that has different implications. And because they're in a flex position rather than an abducted position, usually those other structures aren't as tensioned. Why are we at 45 degrees with internal rotation? We are not. We are at 45 degrees relative to the table, and why are we rotated rather than pure is because if you sat facing the table like you did in external rotation, is that your forearm would eventually get blocked by the edge of the table. So by turning 45 degrees relative to the table, but you're still at a 90 degrees of flexion, you're still in the flexion plane, and you're at 90 degrees at the elbow and 90 degrees of torso relative to the humerus. That is the purpose of being slightly rotated rather than maintaining the original position that you see in external rotation, so that your forearm does not get blocked. But you're not at a 45 degree angle with IR. Structures tension with IR, posterior capsule, yes. Infraspinatus, yes. Teres minor, to some extent, yes. Actually, no, that is accurate. Posterior labrum, yes, but I can't say that's going to be the biggest constraint. Yeah, I think if you've ordered them in, if you listed them in the order of constraint, I would agree with that. Yeah, humerus glides posterior. I would say, yeah. Mm. I'd say predominantly, yeah, maybe posterior and superior is where it wants to go, but then the constraints of the tissue are there because you'll get an obligatory humeral elevation at times. So just being conscious of that and and that's the end of their range when the humeral head escapes up. 150 degrees of arc, approximately. I'm still in the means of developing a good database to pool this data. But yes, so you would expect in the elevated position, people can get up to 45 degrees. And that would be 45 degrees relative to the vertical. And then 90 degrees down to neutral would be okay, but people can go beyond that. So again, I think that 160 is probably a better guesstimate. But I have yet to see a large N of pooled data for that, but that's more anecdotal based off my recall from what I expect in clinical practice. And then finally, so this is usually I do it at 140 degrees rather than 145 degrees, but so be it. And tension on most of the capsule, lats, subscapularis. Yep, Teres major again. Anterior labrum, kind of, but again, because you're not in an abducted position, it's not going to be as tensioned. You could probably also get some of the ligament structures within the um, superior complex of the shoulder as well as being limited. Those that create the roof of the rotator cuff interval and the roof of the subacromial space as well. All right, and then to your final points here. Yeah, I agree with each of these notes from the resources. Yeah, so I hope that helps. I would also encourage you to read the Donatelli article that was published. I believe it was in 2014. I'll attach that as well as a resource. But yeah, that is the algorithmic shoulder range of motion flow.